this lesson, we'll learn about retinopathy of prematurity, also called ROP. Introduction. Retinopathy of prematurity is a developmental vascular proliferative disorder that occurs in the retina of a preterm infant with incomplete retinal vascularization. ROP is an important cause of severe visual impairment in childhood. Other ophthalmologic disorders that occur frequently in preterm infants include amblyopia, strambiasis, and refractive errors. This lesson will review the pathologens, risk factors, classification, screening for ROP, and the management and the prognosis of ROP. Pathogenesis. Narrow retinal vascularization. Vascularization of the retina begins at approximately 16 weeks gestation at the optic nerve and proceeds peripherally. Retinal vessels reach the peripheral of the eye on the nasal side at 32 weeks and on the temporal side at 36 to 40 weeks. The numbers in the figure are weeks of gestation. The pathogenesis of ROP is through into involve two stages. The first one disrupts normal angiogenesis. The second one, neurovascularization. Regulation of the expression of VEGF and other cytokines appear to contribute to both normal retina vessel growth and abnormal vascular disruption and subsequent neurovascularization. Risk factors. The most important risk factor for developing ROP is prematurity. Low BW, low GA, assistant ventilation for longer than 1 week, sufficient therapy, high blood transfusion volume, correlate illness severity, low caloric intake, hyperglycemia, and insulin therapy. Other possible risk factors include spasms, fluctuation in blood gas measurements, intraventricular hemorrhage, bronchopulmonary dysplasia, treatment of anemia of prematurity. The International Classification for Retinopathy of Prematurity provides an uniform approach to determining the extent and the severity of the disease. There are 4 features evaluated. The first one, zone, second one, stage, the third one, extent, and the last one, presence or absence of plus disease. Zone 1. The central zone and the posterior pole of the eye. Zone 2. Circle outside Zone 1 with a radius from the optic nerve to the nasal oral sclera. Zone 3. The remaining outer temporal crescent of the retina. Stage include stage 1 to stage 5, according to this table. Extent is described by dividing the retinal surface into 30 sectors. Plus disease. Additional signs of increased venous dilatation and arterial torsion of the posterior retinal vessels, which can increase in severity to include iris vascular engorgement, poor pupillary dilation, and vitreous haze, was referred to as plus disease in the original classification. Pre-plus disease. There is a spectrum of abnormal dilatation and tortuosity, of which plus disease is the severe form. Pre-plus disease was later described as vascular anomalies of the posterior pole that are insufficient for the diagnosis of plus disease, but that demonstrate more arterial tortuosity and more venous dilation than normal. aggressive posterior ROP, also called APROP. An uncommon, rapidly progressing severe form of ROP is designated APROP was later added to the classification. Characteristic features of this type of ROP are a posterior location, plus disease, and ill-defined nature of the retinopathy, which usually progresses to stage 5 if untreated. From the fundus photograph, we can see the different stage from 1 to 5. The last one is EPROP. Threshold ROP is a term that was previously used to describe the threshold at which treatment was needed. 5 contiguous clock hours or 8 total clock hours of stage 3 and plus disease in zone 1 or 2. Type 1 ROP, also called high-risk prethyroid, treatment should be initiated. Type 1 ROP is defined as any of the following. First one, any stage ROP with plus disease in zone 1. Second, stage 3 ROP without plus disease in zone 1. The third one, stage 2 or 3 ROP with plus disease in zone 2. Screening. Screening standard, all infants with birth weight lower than 1,050 grams or gestational age lower than 30 weeks, BW between 1,050 grams and 2,000 grams, or GA more than 30 weeks. Those clinical course place them at increased risk for ROP. Screening examination. The screening evaluation consists of a comprehensive eye examination performed by an ophthalmologist with expertise in natural disorders. The retina is examined by looking through the pupil with an indirect ophthalmoscope with a 20 or 28 diopter condensing lens. Rectum is very useful. Termination of acute retinal screening examinations based on age and retinal findings. Examinations can be stopped when retina is fully vascularized. Zone 3 retinal vascularization without previous ROP in zone 1 or 2. PMA is 45 weeks and no type 2 ROP or worse ROP. And if previously treated with anti-VEGF injection, follow until at least PMA is 65 weeks. ROP has fully regardless differential diagnosis. Fever is a genetic disorder that appears similar to ROP but occurs in full-term infants. It may present early within the first week of life also. Examination of family members is very important. Genetic counseling and testing can be helpful to identify gene variety in about 50% of parents. Treatment. Anti-VEGF treatment has shown promise for treatment of stage 3 ROP with plus disease in zone 1. Recent clinical studies and trials have been done to test the decelerating dose of anti-VEGF for type 1 or treatment-wanted ROP. Laser therapy achieved higher rates of resolution or regeneration of ROP. Vitrectomy can operate to stage 4 to 5 with retina detachment. Cryotherapy has seldom been used. Follow-up is suggested within 1 week after laser photocoagulation or anti-VEGF injection to ensure that additional treatment is not necessary. Subsequent follow-ups depends on the clinical course. We typically see patients every 1 to 2 weeks in Italy with less frequent evaluations, such as the click course, improves. Prognosis. If ROP progresses leading to retinal detachment, the outcome is really devastating. The CRYORP study showed that at the 15-year follow-up, treatment reduces the risk of unfavorable outcome from 52% to 30%. The same study showed improved outcomes in the treat group for viral acuity at the 3-year, 10-year, and 15-year follow-ups. Summary. Retinopathy of prematurity is a developmental proliferated vascular disorder that occurs in the retina of preterm infants with incomplete retinal vascularization. Treatment for ROP is based on disease severity. After treatment, follow-up examinations are required for infants who remain at risk for ROP progression and for infants with treated ROP who are at risk for recurrency. Okay, that's all for this lesson. Thank you for your attention. See you next time.